Hello and welcome to the SimpleMed Haematology lecture series. My name is Dr Marston Hillier and I'm the Haematology Lead. This lecture series will focus on some core topics in haematology, with the first lectures being on haematological malignancies and myelodysplastic syndromes. But first, today's topic focuses on normal haematopoiesis, or, in other words, what does the bone marrow actually do? This lecture is aimed at preclinical or Phase 1 medical students and allied health professionals, and it is so pitched at that level. Today's learning objectives are: we will aim to describe the normal process of haematopoiesis, identify the key haematological cells and organs involved in this process. We will recognise the importance of iron, B12 and folate in blood cell development, and finally recognise the spleen's role in regulating blood cell populations. Bone marrow refers to the tissues and cells found within the medulla of bones of the axial skeleton in adults. The axial skeleton refers to bones of the skull, vertebral column, and ribs. In children, active bone marrow can also be found throughout all bones in the body, but this is lost as we undergo normal aging. All blood cells, whether they are red blood cells, white blood cells, or specialised cells, start their life in the bone marrow. Bone marrow can be split into two further types: red marrow, or the site of red blood cell production, or secondly, yellow bone marrow. This is the site of white blood cell production. In the photograph in the slide, we can see what normal bone marrow looks like. You can see the sponge-like appearance of the network of trabeculae within the bone. Between these trabeculae will be the cells of the bone marrow. All blood cells, regardless of what type of cell it will ultimately become, starts life as what's known as a multipotent stem cell. These cells have not yet differentiated into their final form. They're one of the few examples of stem cells which persist beyond the embryonic stage. Indeed, humans will have these stem cells until their death. These cells have clinical relevance, as treatments for some blood disorders and leukemias often involve transplanting healthy stem cells from one person to another to potentially cure disease. We'll now talk about what these multipotent stem cells can turn into. These multipotent stem cells split into two further main groups. This process is regulated by the body and is influenced by hormones and cytokines. These stem cells can become either a common myeloid progenitor. This is a precursor cell to cells of the innate immune system and to that of red blood cells. Secondly, it can become a common lymphoid progenitor, a precursor to cells of the adaptive immune system, such as B and T lymphocytes. We're now going to talk about red blood cell synthesis and some of the key steps in forming a mature red blood cell, or erythrocyte. From a common myeloid progenitor, the cell then matures and begins to synthesize the protein haemoglobin. This type of cell, which produces haemoglobin, is called an erythroblast. It contains a lot of cellular machinery to produce the protein haemoglobin in high volumes. At a certain point in the erythroblast life cycle, it is nearly full with haemoglobin, and therefore it reduces the amount of its intracellular components to allow for maximum filling of the cell with haemoglobin. It becomes a reticulocyte, which is a red blood cell so full of haemoglobin that it only has its nucleus remaining. Nearly all the other cellular apparatus, such as the Golgi apparatus, endoplasmic reticulum, are destroyed. The final step in red blood cell production leads to the production of erythrocytes, which lose the nucleus, found in reticulocytes, and undergoes one final change of the structure of the cell by altering its cell membrane from a sphere to a biconcave disc. This final morphological change allows for the maximum surface area to volume ratio, allowing for its size, to allow for erythrocytes to be squeezed through microscopic capillaries. The erythrocyte is the main oxygen-carrying cell in the body. An important question to ask is, how does the body know how much red blood cells it should make at any one time? This, like many systems in the body, is regulated by hormones in a negative feedback loop. Healthy kidneys secrete a hormone called erythropoietin, or EPO for short. The more EPO that's produced, the more red blood cells the bone marrow creates. Kidneys themselves detect low oxygen delivery and in response secrete EPO. This can explain why conditions like COPD, where patients may have long-term hypoxemia, often have what's called a secondary polycythemia, or an increase in the number of red blood cells. This is because kidneys receive less oxygen and therefore create more erythropoietin, which stimulates the bone marrow to create more blood. In addition to states like COPD, you can also have higher than normal amounts of EPO as a normal physiological adaptation to people who live at high altitude. This is because there's a lower partial pressure of oxygen. The role of the kidney in red blood cell production also can explain why patients with chronic kidney disease often are anemic. In these patients, they may require injections of EPO to treat their anemia. We're now going to briefly talk about why iron is such a key part of red blood cell production. Iron has unique molecular properties which make it ideal to act as an oxygen acceptor as part of the protein hemoglobin. Iron deficiency can cause what's known as a microcytic anemia, where there are normal numbers of red blood cells. However, the red blood cells that are present are much smaller than normal because they have a lot less hemoglobin within them. Anemia, as we'll talk about in future sessions, is defined as a measurement of the total concentration of hemoglobin. Alternatively, too much iron can also be a problem for the body. This is a condition known as hemochromatosis and can cause liver damage and heart failure. The most effective treatment for excess iron in the body is removing blood, otherwise called venesection. This is where patients deliberately have blood taken away from them by a healthcare professional. In the olden days, this used to be performed through the application of leeches, although that's no longer performed. Platelets, or thrombocytes, are an important cell involved in blood clotting. They again come from a common myeloid progenitor. However, this cell then differentiates into a very large cell known as a megakaryocyte. A megakaryocyte is a highly specialised cell that, in response to a hormone called thrombopoietin, not erythropoietin, now thrombopoietin, a megakaryocyte instead then releases thousands of small cells known as platelets. Platelets are essentially very small membranous outpouchings of a megakaryocyte. One megakaryocyte can produce thousands of platelets per day. If, in response to certain stimuli, platelets become activated, then it can cause cross-linking of fibrin and the creation of a blood clot. The final cell that the common myeloid progenitor can turn into is called a myeloblast. Myeloblasts are interesting cells which can become any of what are known as the granulocytes. Granulocytes refer to white blood cells which, when viewed under a microscope, have small granules or storage blebs within their cell cytoplasm. These, when stained, often stain very dark. These granules contain powerful enzymes or other proteins, which is used as part of the innate immune system. One of the granulocytes that a myeloblast can become is a monocyte. Monocytes become macrophages, an important phagocytic cell, when they migrate into tissues. If we take a step back for a moment, in addition to the common myeloid progenitor, multipotent stem cells can also become a common lymphoid progenitor. From this, cells of the adaptive immune system, such as B and T lymphocytes, are created. The bone marrow also has an important role in developing a concept called tolerance, where the immune system learns not to attack itself and therefore prevent against autoimmune diseases like type 1 diabetes. In the bone marrow, it is here where early B and T lymphocytes develop their highly specialized B and T cell receptors. The adaptive immune system is complex, and we plan to cover this in further talks. So now that we've learnt about the overall picture of blood cell production, it's important to know some of the key things that the body needs to create blood cells. One of these things is vitamin B12, which is a vitamin found predominantly in animal products. As such, vegetarians, or particularly vegans, are often deficient in this. The body naturally has around 5 years' worth of reserves, and its function is important for DNA replication. An absence of vitamin B12 prevents the body from making the DNA base thymidine. The essential effect of this is to cause cell division to pause. B12 deficiency has a disproportionate effect on synthesis of blood cells because over 90% of daily cell turnover in the body comes from blood cell synthesis. Closely linked to vitamin B12 is folic acid, another dietary vitamin that this time comes from particularly green leafy vegetables. It's involved in the same biochemical pathways as B12 deficiency in that it leads to a reduction in DNA synthesis. A reduction in DNA synthesis means a smaller number of blood cells is created. Folate deficiency is particularly relevant in clinical practice because common drugs can also act as folate antagonists. Classically, this would be the rheumatoid arthritis drug methotrexate. Patients who take methotrexate require folic acid supplementation to reduce the harmful effects of folate deficiency. When the body recognises that it cannot create as many new cells as it likes due to B12 or folate deficiency, it tries to fill up the cells that it already has with as much haemoglobin as possible. This leads to red blood cells that have a larger than normal mean corpuscular volume, or MCV. These cells are full of haemoglobin. The other term for this, where there is anemia in the context of a high MCV, is a megaloblastic anemia. And here's the overall picture so far. To summarise this, a multipotent stem cell splits into one of either a common myeloid progenitor or a common lymphoid progenitor. The myeloid progenitor leads to the production of platelets through megakaryocytes, erythrocytes through reticulocytes and erythroblasts, and granulocytes such as neutrophils and macrophages through the myeloblast. The common lymphoid progenitor forms cells of the adaptive immune system, so the B and T lymphocytes. We've discussed the role of hormones, so of EPO, of thrombopoietin, in the production and stimulation of blood cells. Now we've spoken about how the body makes cells of blood, the next question is how do we remove old ones or damaged ones? Red blood cells and old platelets are removed in something called the reticular endothelial system. This is essentially a fancy name for specialised macrophages which are resident in the liver and spleen. These macrophages recognise old and damaged cells and phagocytose them. These macrophages also have an important role at filtering the blood of harmful bacteria and viruses. They are particularly found in the spleen, which we'll talk about next. The spleen itself has a number of roles. Its main role is arguably as a large storage of red blood cells, with approximately 30% of the total number of red blood cells in the spleen at any one time. If there's bleeding, the spleen can contract and release those red blood cells into the circulation. Under a microscope, the spleen is split up into two parts, called the red pulp and the white pulp. In the red pulp, there are red blood cells and lots of macrophages that seek to remove old, dead or damaged blood cells as part of the reticuloendothelial system. There is also the white pulp. The white pulp essentially acts as other lymphoid tissue, similar to, for example, the tonsils. This is where lymphocytes and antigen-presenting cells meet. However, the main job of the spleen is in regulating red blood cell production. It is possible to live without a spleen, as macrophages in the liver can take up the job of the spleen. However, we need to supplement the immune function that is lost with regular vaccinations and prophylactic antibiotics. In summary, we've discussed that all blood cells come from a common stem cell precursor. We've discussed that red blood cells, white blood cells, and platelets all have their own steps in maturation for different reasons. We've discussed the importance of cofactors such as B12 and folate and why they have a disproportionate effect on the blood system. And finally, we've discussed the role of the spleen and how hormones can affect the production of blood cells. That's the end of this introductory lecture to haematopoiesis. Be sure to check out simplemed.co.uk for hundreds of free articles, thousands of free questions, and for any support with questions you might need. Thank you for listening, and goodbye.